A very good morning to you. I'm Howard Feldman. This is the Sunday Synthesis podcast with me, Howard Feldman, and Dr. Anton Meyberg, pulmonologist and physician, as well as frontline COVID worker. It is the 14th of February. It's Valentine's Day, which makes this, completely relevant to what we're talking about. But nevertheless, happy Valentine's Day. We are here to show our love for you by recording a podcast and answering your questions. Please don't forget to subscribe so that you know when the next podcast becomes available. Dr. Anton Meyberg, good morning. Happy Valentine's Day to you. How are you?
Good morning. There are currently 109,129,405 cases worldwide, with 2.4 million deaths and 81 million cases resolved. The United States has 28 million cases with 496,000 deaths. South Africa has 1,490,063 cases with 47,821 deaths and 2,382 new cases in the last 24 hours, with a positivity rate of 7.6% and a 93% recovery rate. The Gauteng hospitals have 4,026 cases admitted, with 699 in ICU and 417 ventilated. And overall admissions are down by 1,900, with ICU admissions down by over 300.
And the hospital that you work at, how's it looking there compared to where we were over the last couple of weeks?
So the numbers are quite static at the moment. We've still got 2 wards, one ICU ward and one general ward, and then a third PUR ward, which is people under investigation. We're sitting around a static number of about 20 to 25 patients, which has not gone up dramatically, which has not gone down dramatically, which is sort of hovering in a midline there. So we still are seeing cases, we know that, but the number has dramatically decreased over the last few weeks.
Okay, so that is great. Let's just cover some of the big conversations that everyone is talking about, and that is Ivermectin. That is where we are with the vaccine. Let's start with Ivermectin.
Okay, so the Ivermectin debacle still goes on. On last week, there was a study that came out of 5 different tablet formulations of Ivermectin that were sourced and sent to an accredited laboratory. All of these tablets were unregistered. They were brought in from different countries all over the world. They were illegally sold, illegally imported and used. And more than 80% of these tablets had more than one active pharmaceutical ingredient in them over and above the Ivermectin. That means they had things like telmisartan, which is an antihypertensive, which is used for blood pressure, hydroxyzine, which is an antihistamine, diclofenac, which is a non-steroidal anti-inflammatory drug, paracetamol, and a whole host of other medications that were found together with the Ivermectin. So it's not a sole drug that's just used by itself, and you've got to be very careful of the side effects related to that. In the last week, there was also a SAJR webinar where a professor from Israel noted that in his study, there's a very high prevalence to using Ivermectin to help patients in the asymptomatic phase and in the phase where they're non-critically ill. And I think it's very important to understand that this study is not used in people who are hospitalized, in patients with severe disease. We've still had, in our hospital, we've had about 8 patients that started out with mild disease that all took Ivermectin in high doses, and all 8 of those patients demised on the Ivermectin. They all had pulmonary manifestations, they all had neurological manifestations, and they were all extremely ill. So we've still got to be very careful with these very small studies that are popping up every place, from here, from there. When a study is done on 90 patients and 45 are in the placebo arm and 45 are in the actual ethical arm of the study, that's not a phase 3 trial. That's a phase 1 trial. You'd like to have a number of thousands of people in these trials to be able to see what the relevant effects of the drug are. That being said, we would like to believe and would like to hope that one day we might be able to use certain medications as prophylaxis, or to slow down the rate of the transmission of the virus and decrease the viral replication. But we can't get excited yet about a study done on 90 people. We've got to be just cautious, and we've got to watch what's going on all over the world. And you've also got to realize that even in a country like Israel, it's not part of their pharmaceutical dosage or their pharmaceutical arsenal of medication. They're not using Ivermectin as one of their drugs to treat COVID-19.
The contaminated ivermectin, doesn't that rather speak to the fact that it hasn't been legalized? Surely if ivermectin was legalized and the doctors were allowed to simply use it if they thought it was effective, we wouldn't have this whole issue.
You see, we've got to go by SAHPRA on this, and SAHPRA are the governing body, and they do this for a reason, and this is the sole reason for it, that there are going to be people getting in drugs from all different areas and all different places, and we can see there's the animal dosages or animal sort of usage of ivermectin, and the ivermectin is supposedly safe to use in humans. So, albeit that it's what you're saying is 100% correct, that if maybe they left people to their own devices, it wouldn't be like this. But there's always going to be illegal drugs being brought in. There's always going to be non-pharmaceutical or active pharmaceutical ingredients added to these drugs to make them cheaper and to get a bigger amount brought in. So we've got to go by SAHPRA. They're our governing body, and they do things correctly and in a way that we can be protected and protect sort of everybody from these side effects from the drugs.
Do you, as doctors, have clarity on whether, if you want to use ivermectin for, I think it was compassionate reasons or under certain circumstances, do you have clarity as to how to do that? And is it an onerous and time-consuming process? I spoke on my show last week with a GP who is a part of bringing a court application to government, because what they're saying is it takes her like an hour to fill in a form in order to get permission. What's your experience?
That's very correct. It's an onerous, completely time-consuming application to try and get these drugs brought in, whether they're Section 21 or they're brought on compassionate use. But we still don't know from SAHPRA or from any of our governing bodies what the actual dose is that you should be prescribing. And that being said, we as a physician body are still not happy to prescribe the drug without the relevant studies and without the backing of the peer-reviewed studies that will give us the guidance to use these drugs safely and effectively.
Okay, so that's where we are with ivermectin. This is an ongoing story. Has there been any development in terms of the information we spoke about last week with this drug in Israel with a whole lot of names that of letters and numbers? It was basically a password. The name of the drug was a password.
So basically, it's the same as it was last week. 30 people were in the trial, 30 people were studies, massive outpouring of WhatsApps and SMSs and Facebook messages to say what a brilliant drug, and now it's all filtered out. So once again, we've got to be very careful with information we get from very small trials of 30 people or 45 people. We've got to wait for relevant studies, relevant data. And just remember, as I've said many a time, there's no magic bullet. That's not available yet. Be patient. Yeah. Just make sure you wear your masks, do your social distancing, protect yourself from having to need to use these magic bullets.
Right. Let's talk about the vaccine, because we know that now I believe the Johnson & Johnson is on its way to us, 80,000, which doesn't seem like a lot in my view, but give us the latest on the vaccines.
Okay, so you're right. There's about 80,000 Johnson & Johnson supposedly coming in the next week or two. Who will get them out of the healthcare workers? We are yet to find out. Will it be public? Will it be private? Will it be a conglomeration of the whole medical fraternity? Will it be nurses, pharmacists? Who knows? We don't know any of that. But what we do know is that the government have procured 9 million doses of Johnson & Johnson, another 12 million vaccines from COVAX, and another 20 million from Pfizer that are supposedly going to be here by the end of the first quarter. We still know that the AstraZeneca drug does not prevent, or the vaccine does not prevent mild or moderate disease in the SA variant. And that's very important to understand. It doesn't mean that we won't be using it at a later stage, because when the study was done, it was done in a group of young, healthy people that wouldn't be essentially getting the severe type of disease. And even though it's been brought here for medical professionals and health personnel, they would say that about 20% of health personnel would fall into the severe or the critical type of disease from the COVID-19, and 80% would fit into the mild or moderate disease. So in that case, the AstraZeneca is not going to be effective to protect your medical personnel against the vaccine, and that's why they bring in the Johnson & Johnson vaccine. We're hoping at a later stage that the AstraZeneca either can be modified or there'll be a different type of vaccine which will show us how to use AstraZeneca in a better way or for a different subpopulation. Now, also remember, the Johnson & Johnson is not a 95 efficacy. It's about a 65 to 85% efficacy. And there is a very important thing there. You note that when we give the flu vaccine every year, there's only about a 60% efficacy from that, and that's done on a yearly basis. So over 60% is a very good efficacy, and we're very happy to take it. And what's important to remember is that Johnson & Johnson does protect against severe disease, and we know that it protects against severe disease and hospitalization, which is very important. So it's an adenovector vaccine, which uses a double-stranded DNA to promote an immune response in the body. So it's not RNA, it's DNA. And a piece of genetic material from the novel coronavirus spike protein is added to the adenovector 26, and this helps create the immune response from the body. And because it's not a live attenuated virus, it does not make you sick from receiving that vaccine.
A lot of concern about this vaccine changing our DNA.
So it's not true. It's unfounded, especially the Moderna and the Pfizer one, which works on the RNA. It basically doesn't enter the actual nucleus of the cell to change the DNA once it's been ingested into the system and once all the cells take it up. So it does not change your DNA. It does not do a genetic change of your whole chromosomal or cause a chromosomal abnormality.
And what about fertility? Lots and lots of people asking me about this. Is this completely fake news? What is the story? I mean, it's no longer a real concern for me.
No. Yes, I'm just asking for a friend.
I'm blessed to not be worrying about fertility anymore. But a lot of people, in fairness, should be worrying about that if it's a relevant question. Well, the question's relevant. Is it a relevant concern?
So it actually is a reasonable question, and it's a reasonable concern. We know that any febrile illness, that's any illness that causes temperature to be raised for a period of time, can cause a lowering in your sperm production. So more so with an acute virus in the acute phase of the SARS-CoV-2, COVID-19, you may get a lowering of your sperm production, but it's acute and there's no evidence to show that it's long-term or that it's going to go on for a long time post having recovered from COVID-19.
But the vaccine itself?
So the vaccine itself doesn't cause any issues with fertility. There's no issues with fertility. It doesn't change your DNA, doesn't change your RNA. It's a adenovector virus, as we discussed, and it can't cause any damage to fertility from what we know.
Okay, so you would still advise young people not to be overly concerned around that?
Correct.
When you talk about a 65% efficacy, does that refer to that the fact that in 65% of cases, people won't get the virus, or they will only get it very mildly? What does that number actually mean?
So basically it means that sort of 65 people out of 100 people won't get the virus, and of the 35% that do get it, they'll get it much less or much less severe. So the efficacy is very important, and obviously you'd want a 95% efficacy. We know that, and this is a very important point, we know that it's not a cure. The vaccine is not a cure for the virus, and we most likely going to be having this virus as an endemic virus for who knows how long, just like the other 4 coronaviruses that we know about. But very similarly to the flu vaccine and to the flu virus, we're going to need to have boosters every single year once we've reached herd immunity with this virus and with these vaccines.
Our medical aides have become very, very quiet. Discovery, a lot of them, but we haven't heard a word from them around the vaccines. Wouldn't we have thought that they would have been able to procure them and start vaccinating their members? Surely this is an important thing.
Yeah, I think it is a very important, and I think you're spot on with that question. They have become very quiet, and I think there's something in the pipelines there in the medical aid fraternity. I think that, they're waiting almost with bated breath for something to go wrong so they can step in and take over the reins, because we need effective management of this. We need people that we can trust to give out the vaccines. And I think people don't have a lot of faith in the government at this point in time to deal out the vaccines. I know at one stage the medical aides were saying they will vaccinate one person and provide an extra vaccine for public healthcare at the same time. So, I mean, the government would be stupid to not actually accept that offer from the medical aids. But as you said, they've become very quiet. So I think something is in the pipelines, and we'll
But I'm
wait
hoping,
and watch.
because I find it very strange as people who are on private medical aids paying an enormous amount of money. I would have thought the medical aids would at least have been communicating with their members to advise what the story is. And certainly we haven't
I think
seen.
their hands are tied at the moment because they've been told that only the government at the moment is allowed to provide the vaccine.
Well, I would still think that some communication is better than no communication. Otherwise, we're just going to make up what we don't already know. How is South Africa doing in terms of population? How much of our population do you think has actually had COVID-19?
So an interesting study came out, a survey came out on Friday by the National Blood Service, showing a large percentage of the population by extrapolation has already been infected with SARS-CoV-2. And what they did, they noted that people who were blood donors, they looked at different provinces. They looked at Eastern Cape, Northern Cape, Free State, and KwaZulu-Natal. And they noted from the 7th of January to about the 25th of January, with 4,858 people, that 63% of people in the Eastern Cape, 32% in the Northern Cape, 46% in the Free State, and 52% in KwaZulu-Natal, somewhere around there, had antibodies that neutralized the virus. So if we extrapolate this, we can say that there's a larger percentage of people that have had the virus and they've got antibodies than we actually realized. What's also interesting from this survey is they found that non-Caucasians were 3 to 5 times more likely to have antibodies than Caucasians were.
That's interesting. Is this something that we've seen worldwide, or is this a uniquely South African observation?
I don't think we've seen it worldwide. I don't think it's been looked at worldwide, but I think it's a very good survey and a very good study done by the National Blood Service, and I think we're going to see a lot more from it.
That is fascinating, and maybe very good news in the sense that if more people have had it, then perhaps we can reach herd immunity quicker.
Hopefully, we just got to worry about, obviously, the variants and the mutations.
Kim wants to know, how long does it take to get taste and smell back? I am going crazy.
It can take anything from 6 weeks to 6 months. There's no predetermined time. Unfortunately, what the virus does is it attacks the olfactory nerves and all the receptors and cells around there. So it's basically a waiting game.
Belinda wants to know, are there certain conditions or medications that preclude a person from getting the vaccine?
So we are very aware of people with hypersensitivity to vaccines, or people with egg allergies, those type of things, people with severe anaphylaxis who've got to be very careful. There was a worry initially about people who had Guillain-Barré syndrome. That is not a worry at the moment. And what most of the vaccine centers are doing is they keep people at least for 15 to 30 minutes in the vaccine area to make sure there's no anaphylaxis. And they've got a sort of a setup that if there is, they can treat it straight away. What's still interesting, what's still of note, is the discussion around pregnant women, whether or not pregnant women should be vaccinated and people with cancer should be vaccinated. That you need to discuss with your oncologist and with your gynecologist to decide if your risks are much higher. We do know that COVID is more severe in pregnant people. So you've got to balance the studies, and you've got to balance the risks and the pros and the cons about getting vaccinated or not.
Stephen wants to know, what about swimming? In swimming pools, are they safe?
Yeah, there's no problem in swimming pools and chlorinated swimming pools as long as you social distance. That's the most important thing.
And then Craig asked to be kept anonymous, so we are going to keep Craig's question anonymous. He says, my wife and I are having a debate as to whether I can go back to gym. I say yes, and her answer is obviously no. Just wondering if I could please ask this, but anonymously. So, and if you can just keep Craig's answer absolutely anonymous, and his question as well, I would appreciate it. Thank you.
So I'll fill out Craig's list. And basically what I can say from that is, personally, I am not going back to gym right now. I don't think it's safe enough to go back. We are waiting for the numbers to come down further. But what I do know in most of the gyms is they allow people not to wear masks when they're doing aerobic exercises. You're in a contained environment with poor sort of ventilation. It's a high-risk area to spread virus. So you've got to be very careful and maybe just hold out for a little bit longer, unless you can go to a place that's outside where people are wearing masks and do it in that type of environment.
And Colin also wants to remain anonymous. He says he wants to know about his older kids, late teens, early 20s, having social getting-togethers, things like that.
Well, I think, all the kids can bake up a storm, literally. It all depends on the fact that how responsible they are and what they need to do. And if they're going to actually follow the rules, wear masks, sit outside, socially distance, there is some room to play around. The problem comes in is when they take off their masks and they're eating together and they're on top of each other and there's no control. And we're talking about older kids here. We're not talking about 4-year-olds or 5-year-old play dates, because those are still taboo, because there's no control of what the young kids do.
Right.
Those are still taboo. You've got to be very careful. School is very different to a play date. School is very controlled, very moderated. There's people watching them the whole time. Unless you can definitively say that you can watch the children playing the whole time, make sure they're wearing their masks, they're not touching each other, they're social distance, then we can talk about it, but it's very unlikely.
So would you say that from around teenager, where we can hope that they'll be responsible, that don't have play dates before that?
Yeah, I think it's all about responsibility. And I'm saying, we obviously don't want play dates. It's better not to have play dates. It's better to just keep it simple and not spread the virus. But the reality of the fact is people are human and people have had enough. And you can't keep people locked up forever. So if you're going to do something, do it responsibly, do it safely, do it carefully, so that you're not affecting other people. And if there is a problem, you've worn your mask, you've socially distanced. And if you go into somebody's house and they turn out to be positive, there's no issue with you having had an issue being there because of the fact that you were wearing a mask and you're socially distanced and you didn't put yourself in a position.
I just want to go through, there are a number of questions that we've got about the work environment. So I'm just going to go through a whole bunch of questions fairly quickly. If people return to the office, the recommended distance seated between people is?
So the recommended seated distance is 1.5 to 2 meters. I must say, and this is a very important fact, that people get this wrong. Just because you're 1.5 to 2 meters away does not mean you don't have to wear a mask.
That was
you
my
still
next question.
have to wear masks. There's no doubt about it. If you're sitting outside more than 6 meters away, then there's room to take off your masks. But even if you're sitting outside 1.5 meters away, you still have to wear masks. We have to prevent this virus from spreading, and that's the way to do it responsibly.
Someone sitting at their desk, we're working with a mask. Can they take off masks to eat something, drink something at their desk?
So it all depends about the ventilation of the office and how many people are around them. If you've got somebody less than 1.5 meters, rather go outside to eat. Safer, better, and easier.
Right. Are there things that should prevent people from coming back to the office if they've been on a domestic flight, an international flight, been at a hospital, been for testing, maybe not because they're ill, but they've been to a testing station where maybe there's a higher incident of people there with COVID? So
if one person is going to a testing station, it means they need to be worried. They are worried about something, whether they've been in contact with somebody or they've got symptoms, and they should wait for results and make sure they've got no symptoms. With regards to local flights, we're much less worried than we were at the beginning of January after the holidays and after people traveling together. So if you've been on a local flight, you don't have to quarantine. You just make sure you're wearing your mask and most likely a visor, and you can go back to work. You just got to be very careful with these situations and make sure that you're following all the rules.
So there isn't really a specific place that you've been to at this point that should preclude you from coming into the office. It's really about if you've been in contact with somebody and or if you're symptomatic.
That's it, 100% spot on. If you're symptomatic, if you've been in contact with somebody that's symptomatic, you've been in contact with somebody, even if they're asymptomatic and you found that they're positive, then you need to stay away from the office. You've got to quarantine for your 10 days or isolate for your 10 days accordingly, and make sure you protect yourself and protect other people. But that being said, even with that, if you follow the rules correctly and you keep more than 1.5 to 2 meters at work with masks on, you've had less of a chance of infecting people and causing trouble at the work environment.
And most work environments have appointed a person responsible for this. So just make sure that you keep that person updated, that they are aware of the situation. When can we anticipate the dreaded third wave? We are now in the middle of February.
So according to most people, we're looking at April, May. I mean, that's the most likely timing. It starts to get a bit colder. There's all holidays, there's Easter, there's Passover, there's all other holidays. Unfortunately, people start congregating together again, and these lead to spikes and surges. So we are anticipating with the winter months and the holidays coming up that it will be around April, May.
There was one question that I'm going to assume is going to help lead to the good news question, and I just don't know how well you're going to respond to this question, but let me just find it for you. Tanya wants to know what happened to LFC. Is that maybe a vaccine side effect?
So that's a very, very good question. And I think I'll address that in the good news. Okay. And the good news is as follows. The positivity rate is down dramatically to 7.6%. The numbers are down dramatically, and we are definitely over the second surge. And albeit Liverpool is not performing at this point in time, they are still champions. They are still on top of everything else from regards to supporters, and real supporters never let their team walk alone. And yes, there are rumors that 99.999% of Liverpool may have had COVID and have got brain fog now. But remember one thing, you'll never walk alone and we'll always be the champions. And to quote, be careful when you follow the masses. Sometimes the M is silent. Have a good week, be safe, look after yourself, and continue doing what you're doing in order to keep us all safe.
Dr. Anton Meyberg, thank you. I'm Howard Feldman. This has been the Sunday podcast, the Synthesis podcast. Please don't forget to subscribe below. Have a fantastic day. Have a wonderful Valentine's Day from us here this Sunday. Hope it's good. Hope you show love. I hope you receive love. Be safe. God bless. See you next week.